Dr. Sumit Monga, yeah, your presentation is on saviors in strabismus practice. I invite you to present your.
There's somebody else in there.
I thought she's not coming.
No, Chandra. You'll wait.
Excuse me, can we, yeah. So good evening, everyone, and thanks for the kind opportunity. So, in fact, due to the limited availability of the data on, the therapeutic use of prisms in the strabismus, we thought that we'll just evaluate our own data. So we retrospectively studied cases of strabismus managed with prisms seen at 3 of our centers in Delhi NCR over a period of 5 years, COVID era included, who had more than 6 months of follow-up. So these were cases of strabismus who were managed with prisms, both Fresnel prisms as well as the ground prisms. So we had the success measured when they had responded to the prisms by resolution of diplopia, or the alignment led to the binocularity restoration and the uh, betterment of abdominal head posture. So 120 of 154 patients were included for analysis, and they had a mean age of 7.6 years and mean follow-up of 13 months. Majority of these cases were managed with Fresnel prisms, which are stick-on prisms that you actually put over the glasses. So sharing some of the interesting cases, we had this gentleman who was managed with Fresnel prisms for his right lateral rectus paresis for diplopia relief. Another case of partially commutative esotropia, where segmental Fresnel prisms were applied over the distant segment of the bifocal to manage and preserve the binocular vision. Then we had a consecutive esotropia and hypodeviation, which was managed during the COVID period for almost 2 years before a definitive surgery could be done. And an innovative oblique placement of the Fresnel prisms was tried in one of the case, where the case was of bilateral Duane syndrome, and this helped in betterment of the abdominal head posture. So most of our cases were esotropes, and the better outcomes were seen in intermittent exotropes and cases which had lesser onset of deviation. So just to recapitulate, the Fresnel prisms is a stick-on prism, which is a thin transparent sheet, much thinner and lighter compared to the regular ground prisms. So this therapeutic use of prisms has been studied earlier, but ours was a larger series and had a much younger profile, with 7.8 is the mean age, and 78 out of 120 children were cases were children. So we had included binocularity as one of the criteria for success, which has not been done earlier. So this was a major plus point of the study. The limitation of the prisms was the cost, the intolerance to prisms, and the uh, temporary intervention method. So in short, the usage of the study was that eye care personnel anywhere, even at remote locations, can actually use prisms as a stopgap measure to treat strabismus. And the conclusion that we had from the study was that in selected cases, the prisms are an effective non-surgical option that we can use to manage many cases. Thank you very much.
Did you find any association between the etiology and the type of prism which you are using?
Yeah, so actually, since we had a broader success criteria, many cases of esotropia already had a poor binocular vision. So those responded a little less. That's why our success is probably less than what has been reported in literature. But we wanted to determine the efficacy overall, and as a methodology, to help in the restoration of the alignment, this is an excellent method.
Right. Thank you.
Thank you, ma'am. Thank you very much.
So let's call upon Dr. Chandra Devi. And the topic is risk factors, management and prognosis of patients with post-cataract surgery wound infection. Can we have the timer also? All right. Yeah. So on.
Good evening, everyone. I'm here to present my study on the risk factors, management, and prognosis of patients with post-cataract surgery wound infection. I would like to thank AIOS, APO, and Professor Namrata Sharma for this opportunity. Cataract surgery is one of the most common elective surgical procedure which is performed worldwide. SICS is a commonly used technique in developing countries like India, whereas phacoemulsification is commonly practiced in developed countries. Higher rates of post-operative endophthalmitis have been reported with SICS compared with phacoemulsification. Post-cataract surgery infection have always considered endophthalmitis, whereas wound site infection is often underdiagnosed or not reported. So my aim of the study is to evaluate the socio-demographic profile, risk factors of patients presenting with post-cataract surgery wound infection, to identify the causative organisms associated with the infection, to evaluate the outcome and prognosis in these patients. It is an ambidextrous institutional study which is conducted over a period of 18 months. The patient with post-cataract surgery wound infection who is presenting to the emergency department or the OPD were recruited in the study. Demographic details, risk factors, place of surgery, time of onset, everything was noted, and microbiological investigations were done, and the patients were managed accordingly. The follow-up period were, the patients were followed up for a period of 6 months. So we collected around 18 patients. The average age of the patients were 63 years plus or minus 5 years, and the type of surgery done was most commonly SICS in 17 patients, and 1 patient with presented with phaco wound infection. The average time of presentation is within a week in 14 patients. The site of infection involved is a superior sclera, which extends to about 1 to 2 clock hours, and there was about superior corneal infiltrate in 66.67% of patients, and 72% of patients presented with hyperpion, and 44% of patients had associated endophthalmitis. So this is a microbiological report where the gram staining revealed gram-positive cocci in 2 patients and K-watch was negative. On culture sensitivity, 10 patients, the culture sensitivity was sterile, whereas 3 patients were positive for Staph aureus, 2 patients were positive for fungal infection, which include Fusarium and Aspergillus, and 1 patient was positive for Pseudomonas, and 2 patients were positive for Staph species. So 7 patients were managed medically. 1 patient required blue BCL. 2 patients were treated with therapeutic PK, and 4 patients were required intravitreal antibiotics, and 4 patients required end of vitrectomy. So the duration taken for recovery in our patients were about 30 days to 90 days. The common risk factor identified was the patient who has been operated at a district hospital or small center carried higher risk, and scleral thinning and uncontrolled systemic illness also carried a higher risk for infection. The average visual gain was around logMAR 2.4 plus or minus 0.8 units, and most of the patients responded to topical and systemic antibiotics. Early onset infection carries a poorer prognosis compared to late onset. There was 1 patient who has developed fungal infection, had an extensive corneal and scleral involvement. That patient eventually resulted in phthisis bulbi. So this is a patient who had scleral tunnel infection with superior corneal thinning. The patient was treated with blue BCL. This is 2 patients who had late onset tunnel infections. And this is a patient who had phaco tunnel infection. You can see here the phaco wound, and there is uveal tissue prolapse through the phaco wound. And this is a patient who has been managed with end of vitrectomy and with silicone oil in situ. We can see the silicone oil in situ in the AC. There is 1 patient who presented with scleral necrosis. It is basically a sterile necrosis due to excessive cautery. The patient has undergone scleral patch graft, but the patient is following with a good vision of around 612. So outcomes of post-cataract surgery wound infection is generally poor. Early identification of the complication and prompt referral helps in vision or globe salvage. Bacterial infection is more commonly encountered in these cases. So we should follow uniform guidelines for ACSS. Use of preoperative or intracameral antibiotics can reduce the risk of infection. Thank you.
So what were those predisposing conditions which you were seeing in majority of these patients who reported to you with these infections?
Many of the patients have been operated in a peripheral centers where we doesn't know about the aseptic precautions which has been followed, and about the preoperative antibiotics which we have been used or not, and they have been operated in camps. So preoperative precautions should be followed.
Was betadine used for these patients or not? Because that takes care of a lot of these problems.
Yeah, but all these patients were referred patients, so we don't know about the intraoperative.
Okay.
All right, thank you.
Thank you, ma'am.
Thank you so much. Is Dr. Adhikari here? Okay. So, we'd like to invite you over to present on moderate to high astigmatism in older children, a study of treatment modalities.
So please give my paper.
Dr. Adhikari.
Ah, yes. It's not showing. तो देख क्या है तो ये इसमें हाँ नहीं तो देख क्या आया था तो
Anybody else who's here ready? Can I have your name?
बोला ना तो हाँ अच्छा
Vidham.
हाँ so I have to scroll down okay good evening all. My selected topic is moderate to high astigmatism in older children, a study of treatment modalities. So, astigmatism is a common condition and it is due to rotational asymmetry of the refractive power of the eye. Since it is a common thing but rare to pick, and thankful to AIOS committee for choosing the topic to compare the effects of refractive error correction versus refractive error correction and amblyopia management in older children greater than 7 years with moderate to high astigmatism. In this connection, moderate astigmatism we take at around 1.5 diopter of astigmatism. And this is a retrospective observational study. 60 patients are divided into two groups with 30 patients each who have moderate to high astigmatism with glass correction given to all patients who are greater than 7 years of age in the first group. The second group patients have been treated by penalization or patching of better eye 3 to 6 hours daily in addition. All patients were checked with glass or contact lenses. Contact lenses patients only 2% of the total for visual acuity in both the eyes at 4 monthly intervals in both the groups. The age group is 7 to 14 years old. So cycloplegic refraction was performed in all patients. The second group have been checked for proper patching and asked for penalization, optical or pharmacological. Its duration from their guardians. All patients were checked with glasses or contact lenses for visual acuity in both the eyes at 4 monthly intervals. Excuse me. The study was conducted for 17 months, starting from June 2022 to November 2023. In group, patient treated with refractive error only correction, mean visual acuity was 6 by 24 to 6 by 18, logmar 0.6 to 0.5, and the other group that was similar, but while continuing the treatment, mean visual acuity in the refractive error correction only group, it was at the end of 17 months of treatment, no alteration, but in the group treated with the patching or penalization, it has improved in 12 patients to 0.5 and 8 months and 17 months of treatment. And in the second group, 2 patients have gained vision to 0.2 logmar, that is equivalent to 6 by 9. Any case of eye injury, one-eyed patient, congenital anomalies or keratoconus are excluded from this study. Patching or penalization was meticulously done. Strict adherence to follow-up visits have been made. Black paper or cloth which was taped to face, not to glass, was used for patching. Atropine 1% eye drop was used for penalization. Patching or penalization, if done sufficiently early, along with refractive error correction, even in older children with mild to moderate astigmatism, will bring good sustained visual recovery. Thank you.
What was the compliance with these patients? I mean, any of those children, because normally we've seen that they really don't comply well with patching, especially if it's 3 to 6 hours. It's
compliance was very good. Since I deal with patients from a selected group only, government sector, so they usually comply. And almost 85% of the patients means guardians complied.
What was your selection criteria to put these children into the two groups?
Since it is a retrospective study, and I saw many patients who are amblyopic, so they were randomly picked actually, and it is a retrospective study, so guidelines only, there is a vision. When improved, then I divided into two groups. 60 patients I have taken. It can be a larger study, a more prospective trial can be used in future cases. But only after seeing the results, then vision is the main thing. So I have divided them and selected.
the vision didn't improve more than 6/12 in these patients?
Yeah, 6/9 also in two patients.
Okay.
All right, thank you so much.
Thank you, ma'am. Thank you.
Dr. Jenny Seller is present. I think Dr. Rhythm.
So Dr. Rhythm is going to be presenting a retrospective analysis of clinical presentation and visual outcomes in stratosma syndrome.
So a very good afternoon to all of you. I shall be speaking about the clinical presentation and visual outcomes in stratosma syndrome. I have no financial disclosures to make. As we all know, stratosma syndrome is a triad consisting of myopia, myelinated retinal nerve fibers, and anisometropic amblyopia. Stratosma et al. First reported 4 cases of stratosma syndrome in 1967. So this is basically a large case series from a tertiary care center involving different age groups with different outcomes. So we did a retrospective analysis of the electronic medical records for a period of 7 years and included all the patients with typical stratosma syndrome. Visual acuity, investigations and treatment outcomes were recorded. In all, we have 14 patients and majority of them were males. The mean age of presentation was around 23 years and family history was positive in 14% patients. Majority of the patients had severe myopia, which was more than 12 diopter. At presentation, majority of the patient had uncorrected visual acuity less than 20/400, but after intervention, we had a couple of cases with visual acuity better than 20/100. The most common association with this syndrome was optic nerve hypoplasia in our study. Nystagmus and posterior staphylomas were also seen. So these are the patient charts. So these are the associations. The first picture is showing esotropia. The second picture showing developmental cataract. We can also see B scan demonstrating optic dystrusions and posterior staphyloma in the fourth picture. So these were the records which we found. The extensive retinal myelinated nerve fibers can be seen in the first picture with hyperreflectivity on OCT due to the presence of these myelinated nerve fibers. And also on OCTA, we can see that there is hyperreflectivity corresponding to the presence of myelinated retinal nerve fibers. So majority of the patients in previous studies have been reported to have variable visual prognosis. But in our patient, we had 35% patients who had visual acuity 20/100 or better. So optic nerve hypoplasia, as reported earlier, was commonly seen in our study also.
And patients with squint had poor prognosis in our study also, as reported earlier. But different in our study was that we found that we could have good visual outcomes if we intervene early and treat these patients properly. We had 2 patients in whom cataract surgery was done and proper patching was done, and we could attain 20/40 visual acuity in these 2 patients at the last follow-up. So associated anomalies like cataract need to be treated, extensive refractive error correction as with cycloplegic correction, and patching is to be done. So this is basically a large case series of strabismus syndrome, and depending upon the age of intervention, type of myelinated nerve fiber, severity of refractive error, we can have variable outcomes. These are my references. Thank you.
Do you know any entity called
Reverse, yes, it is
strabismus
basically
syndrome?
hypermetropia, and we did not include those patients. We found while we were reviewing the records, we found 2 patients with reverse strabismus syndrome also, but we didn't include that. We concentrated on the strabismus only in this study.
So in this study, which was the most commonest anomaly, number 1, number 2, which you
Optic
saw
nerve
among the patients?
hypoplasia was the most common association. In 9 patients, we reported that. Then we have posterior staphylomas, and we also had the presence of squint in 2 patients and also nystagmus in 2 patients.
How did you go about the management in these
Yes,
patients?
management. So basically, 2 patients also had developmental cataract. So we underwent cataract surgery in these patients, followed by full cycloplegic refraction, and then we had to do patching also, 4 hours patching. At least for a period of 2 years we did, and we could attain 20/40 in these 2 patients. I've written it, mentioned in this. So just a second.
What about the squint in these cases? Do you address
Esotropia.
it?
Yeah, we could not perform squint surgeries in 2 patients we had. We didn't have the records of the squint surgery. We could not, maybe the patient, because this was a retrospective study, I think the parents were not motivated enough to undergo squint surgery at that point of time. So squint surgery was not done in these patients. It was not a prospective study. So we don't have records of that. Just it was like we did the cycloplegic correction in those patients.
All right, thank you.
Thank you.
Thank you. Anybody else left who wants to be part of this presentation? Okay, good. Hi, Samresh. So we welcome Dr. Samresh Srivastava for the next presentation, evaluation of clear corneal incision following manual and femtosecond laser-assisted cataract surgery.
Can I have my slides on? Yeah. All right. So cataract surgery has been there for almost 3 decades now in terms of photoemulsification. But there are many things that go unnoticed because we've gotten on from that fight of disassembling the nucleus to giving a good surgical outcomes in terms of vision. But find things like unknown Descemet's detachments will often turn up in your clinic, and they'll cause subclinical or sometimes even manifest good corneal edema on post-op day 1. So we decided to understand why these are happening and whether incision, either clinically and histomorphologically, manual versus femtosecond, would have any bearing on an uneventful cataract surgery purely from Descemet's detachment point of view. This was a prospective randomized clinical trial. Randomization was between group 1 and group 2, which is group 1, which is undergoing a manual incision. Second group undergoes a manual incision with a little bit of flare. The exclusion criteria was any other coat diseases and a very hard grade of cataract. Standard surgical technique was performed. Group 1, which was 150 eyes, had 2.2 millimeter entry with the geometric incision, as would normally do. Group 2 had a flare or an internal flare. We would do an incision and we would flare it up internally based on the clinician's judgment with the same blade, and it was an anterior beveled knife. And group 3 was a femtosecond incision with an external entry of 2.2 and an internal entry of 2.3 millimeters. We looked at Descemet's detachment clinically, asking the surgeon whether they could see a Descemet's detachment, and using an anterior segment OCT to see at the end of 1 hour of surgery whether they could pick up a subtle Descemet's detachment. Also, parallelly, we did a histomorphological study using femto incisions and manual incisions on cadaveric eyes that were subjected to fixing and then looking at the incision morphology. If you look at the results, the grade of cataract was comparable in all the groups. The flax group had a slightly higher age bracket, but that's probably because they chose it that way. Energy dissipation was the least in femtosecond group, as is expected because the chops were pretty much done beforehand. If you look at the clinical decimus detachment, both the group 1, which is the manual incision, and the manual incision with an internal flare showed pretty much detachment in the clinical judgment. Also, when we looked at AIOS, the detachment was the least when was seen with the femtosecond incision. This is just to show you a sample showing flax incision. There is slight gaping at the endothelial site and maybe a subtle detachment, but more or less the incision is organized and kept well opposed. Compare it to a manual incision where you can see the gaping is much more and the decimus detachment is pretty apparent. Again, this reflected again in the same thing. So endothelial misalignment was also significantly higher with both the manual incisions and was low using the flax trapezoidal incision. Although slit lamp, we didn't pick up anything. When we look at cadaveric eyes on histomorphology, and this is just to show you how histomorphology slides look, on the left is a manual incision where you can see that there is misalignment of the floor and roof because it's slid through, probably also due to maneuverability, while the femtosecond incision shows a slightly more alignment as compared to a manual insert. When we look at collagen disorganization, this is evident over there. There's more collagen disorganization using a blade as looking to a femtosecond incision. It has been shown that it is very important to keep an eye on incisions when you're doing a surgery because it's the distortion more than the size that you do. It's not a fight between 1.8 or a 2.2 or a 2.4, but the insult that you do as a surgeon that makes a lot of difference. And also sometimes incompatibly and doing a wound assisted push delivery can really spoil the incision. Surgical technique also plays a great role. So to understand decimus detachment, if it happens and in the hands of an early surgeon, can lead to a big catastrophe if you cause a corneal edema or do a detachment, complete detachment. And that's why it needs to be picked up. So to conclude, our study showed that decimus detachment does happen in as close to 80% people if you look critically. A trapezoidal configuration, while manually can be done, is not titrable, and therefore sometimes technology like femtosecond may come to rescue and give you better outcomes. Thank you.
So these studies which you did on the incisions, were they done immediately, like after how long?
So madam, we had a cooling period of 1 hour while the patient was being discharged. So once the patient's been discharged from the surgery and went down to the OP, that is when we did it for all patients. And the randomization was only between the incision because flax was not our call, whatever the patient picked up.
Okay.
So how long was this observation done on these patients?
So madam, this observation is only on first post-op day. The next paper will be on long-term outcomes, but most of these decimes will stick back because as the endothelium pump picks up, it's going to cause a slow closure. And at the end of, say, glass appointment, which for me is 10 days, generally most patients will not show decimus detachment because decimus will stick back on its place automatically.
So if I give you a time frame of 6 months, what do you think will be the comparison between the two?
I think both will look the same.
Yeah.
Right. All right. Thank you so much.
Thank you. Anybody else who has to present? Okay, so Dr. Zakara is going to be presenting on the comparative assessment of flax in MICS in senile mature cataracts.
Good afternoon all. Let's discuss about the comparative assessment of femtolaser assisted cataract surgery and minimal invasive cataract surgery in senile mature cataract. Nowadays people are coming to the cataract OPD thinking like they will get best vision after the cataract surgery irrespective of the patient age or the grade of the cataract. So the surgical precision, accuracy and the post-operative comfort is the need of the hour. Irrespective of whatever the surgery is, whether it is an MIC or flax, mature cataract has various surgical challenges. This novel study focuses on the mature cataract and its set of unique challenges. And our aim is to assess and compare the effectiveness of flax and MICS in evaluating intraoperative performance and the postoperative outcomes in senile mature cataract. And we compared vision, IOP, corneal parameters, both pre-op and post-op, and also the intraoperative parameters. And it was a prospective comparative observational study conducted over 15 to 18 months over a group of 72 people, 36 in each group, and operated by a single surgeon. And we included all the well-dilated pupil with mature cataract and aged more than 50 years with clear cornea and no other ocular pathologies and no history of previous ocular surgeries. And we calculated central corneal thickness, endothelial cell density, coefficient of variation, and endothelial hexagonality with the help of specular microscopy, both preoperatively and postoperatively. And intraoperatively, we evaluated the cumulative dissipated energy, total surgical time taken for the procedure, amount of balanced salt solution used in both FLACS and MICS procedures, and how the circularity is made in FLACS and MICS, and whether there is any intraocular complications happening during the procedures. And the intraoperative results, when we compare, there is a significant difference between the FLACS and MICS when we are comparing the circularity of the rexus. There is circular central rexus in FLACS, 88.9%, which is more when compared to the MICS. But the number of capsular tags which are seen in the FLACS are more when compared to MICS. Same like CD, cumulative dissipated energy, time, and balanced salt solution used in FLACS are lesser when compared to the MICS. And there is a significant difference in the percentage change of the central corneal thickness from day 1 to the day 30th, which includes the value in day 7. We calculated the values with the help of Pentacam. And a significant change was there in MICS group where the central corneal thickness was more post-op 1 month when compared to the FLACS. Similarly, percentage change of coefficient of variation and percentage change of endothelial cell density shows significant difference between the FLACS and MICS, where FLACS shows a better result. And these are some other studies which show similar results like us, whether a preoperative and postoperative pachymetry shows MICS have a more central corneal thickness post-op 1 month when compared to the LensX group, and post-op endothelial cell density value post-op 1 month showing better endothelial preservation in LensX groups. Now we know that intraoperatively with the help of laser, we can able to make a central circular proper size rexus. Even the number of capsular tags are more. With the proper size rexus, the position of the lens, we can able to keep it properly, which help in the effective lens position, and later on helps in the vision of the patient. And also we are using grid pattern of the laser, which will help in the removal of the cataractous lens later on, which will reduce the cumulative dissipated energy, which we are using intraoperatively. That itself will reduce the operating time and the amount of fluid used intraoperatively. And all these factors which help in the better endothelial cell preservation in the postoperative period. And the percentage change of the central corneal thickness was significant in both groups, where MICS shows more increase in value of the central corneal thickness postoperative 1 month. And whatever the central corneal changes or the intraoperative parameters, post of 1 month, patient was like vision-wise, IOP-wise, corneal clarity, anterior chamber inflammation, from every aspect, patient was like similar in both MICS and FLACS group. And like limitations, I didn't assess the effective lens position and couldn't able to compare the keratometric changes because we are not putting the incision with laser, and sample size and follow-up was less. And FLACS as a superior edge of the edge over the MICS over superior circularity of the capsulotomy, lower cumulative dissipated energy, shorter surgical time, less fluid used intraoperatively, and better endothelial cell protection postoperatively makes it the surgical efficiency of the FLACS is better as compared to MICS in senile mature cataract. Thank you.
So, according to you, which all were the shortcomings in your study? What were the shortcomings in this study of yours?
The
You did
sample
tabulate
size.
few of them.
Which was this shortcoming in your study?
Like
One shortcoming that you think was
negatives.
Yeah, negatives.
In the study, in FLACS groups. Like limitations mainly, ma'am, actually, if the incision was there, post-operative astigmatism, how it is. When we are making the corneal incision with manually and with the lens, whether it is affecting the post-operative astigmatism, we could have assessed properly if the incision comparison we had done. Then the another one is we only refer the patient for follow up the patient for 1 month. So in that 1 month period, the corneal thickness and the endothelial cell count, we couldn't able to assess properly. If it was a minimum 6 month study, I should have assessed it more properly, and the effective lens position other ones, because the central circular proper rexus we can able to make with the laser procedures. So because of that, if manually, whether we can chance that we can make a bigger rexus or a smaller rexus, which can cause a hyperopic shift and myopic shift later on in the postoperative period. Here actually in the laser it should be a proper central rexus which help in the effective lens position. That I couldn't able to assess because I couldn't able to check the effective lens position in my study.
All right, thank you.
Thank you.
Thank you.
Sudhir, Dr. Sudhir.
So Dr. Sudhi is going to talk about axial stability assessment of Clarion IOLs in short and long eyes post-cataract surgery.
Good evening, everyone. I'll be talking about axial stability assessment of Clarion IOLs in short and long eyes post-cataract surgery. No financial disclosures. Clarion monofocal IOL is the next generation hydrophobic aspheric IOL, and the post-marketing studies done in India and abroad has shown an excellent visual outcomes, no surface A's or glistenings, and less of yak capsulotomy rates. And IOL stability was confirmed as a safety endpoint in all these studies. And similar results were seen in the 3-year follow-up study, but all these were done in eyes with a normal range which is 21 to 26. No extremes were enrolled. So the unmet need was we wanted to look into how these IOLs perform in extremes of axial length less than 22.5 and greater than 24.5. And scientific rationale is axial stability is crucial for predictive refractive outcomes, and deviation in IOL position can result in suboptimal outcomes and increased cost. And Clarion IOL is based on Alcon's Acrisoft IQ IOL design and is expected to maintain same stability across various bag sizes due to its advanced biomaterial. So the study involved enrollment of patients who are in the axial length less than 22.5 and greater than 24.5 and with a preoperative astigmatism less than 1 diopter. So all these patients have a routine examination. Apart from that, they had an optical biometry using IOL master at multiple intervals like 1 week, 1 month and 3 months post-operatively. And this included 30 eyes in both the groups and was done by a single surgeon using a IOL power calculation using a Barrett Universal 2 calculator. These were the assessment schedules which were done at various visits. So the anterior chamber length measurements was done at 1 week, 1 month and 3 months, whereas the visual refraction was done at 1 month and 4 weeks. So these were the results which showed that we had in the short eyes the range of axial length was between 21 to 22.5, and whereas in long eyes it was from 24.54 to almost 31.01. So we measured the anterior chamber depth at 1 week. In case of short eyes it was 4.30 and which was almost same, and it increased by little at 4 weeks and 12 weeks but remained stable, whereas in long eyes the axial length was slightly reduced and then maintained at 1 week and so at 4 weeks and 12 weeks. So the differences were not significant except for in the long eyes at 1 week and comparing with the 4 weeks there was a slight reduction that could be explained because of retained visco which could have got absorbed, and then it maintained the axial stability. So we also looked at the refraction changes at 4 weeks and 12 weeks. It was stable and there was no change in the refraction, and the spherical equivalent was also well achieved in all these IOLs. So the axial stability of Clarion IOL was evaluated using serial anterior chamber depth measurements, refractive error assessment and visual acuity, and there was no statistically significant difference was observed in ACD measurements over a 12-week follow-up period. Stable refraction was noted during 1 month and 3 months follow-up visits. The previous study had compared between Alcon IQ lens versus Clarion IOL. They had found there was a difference in the anterior chamber depth at 1 week to 6 months, but the measurement should be done at least 1 month so that the stability can be checked. So in our study that at 1 month and 3 months it was stable. To conclude, that study findings suggest that Clarion IOL demonstrate favorable axial stability in all eyes and extremes of axial length, and this implies that ophthalmic surgeons can confidently consider Clarion IOLs for patients with varying axial lengths, ensuring reliable post-operative outcomes and potentially improved visual results. Thank you.
Any study done with the toric Clarion also?
This was done just before the toric was introduced in the Clarion platform.
All right.
So that's why we had to use.
This was your limitation. Thank you.
Dr. Rishu. Rishu.
What are you talking about?
Ma'am, IOL power comparison and post-op results with different IOL. Rishu.
Study.
Study like comparative evaluation of post-op refraction with using different IOL.
Yeah, this is the last one.
A very warm good evening to respected judges and fellow presenters. My topic of today's presentation is comparative evaluation of post-op refraction in patients operated with 4 different brands of IOL. The purpose of the study is to compare visual outcomes after cataract surgery using 4 IOLs of different prices but similar properties. All the lenses are monofocal hydrophobic acrylic but belong to a variable price range. It is a prospective randomized controlled clinical trial, duration of 6 months, and included 125 AIOS2025 patients who underwent phacoemulsification and IOL implantation. Eligible patients were randomly assigned to one of the 4 different IOL implantation groups according to the patient preference in lens selection. These are the IOLs used. And the patients were excluded based on like there is no history of ocular inflammation, trauma, diabetic retinopathy, uveitis, glaucoma. This ensured that the study focused on a homogeneous group of patients with primary age-related cataract, and the preoperative assessment included ophthalmic evaluation and biometry using IOL Master 700, which provided precise measurements, and axial and keratometry and IOL powers were calculated. So the preoperative data consists of the mean age of the patients in each group, sex distribution, mean axial length, and keratometric values. No statistically significant difference between 4 IOL groups with respect to axial length keratometry. Hence, the visual outcome following cataract surgery is unlikely to be affected by these parameters. And the surgery was performed by a single experienced surgeon using standard phacoemulsification techniques, and the selected IOL were implanted into the posterior chamber. And the post-operative assessment was conducted on day 1, 7, and day 30, and the following parameters are recorded, and there is no intraoperative or post-operative complication in any of the study group. So the results are as follows, and the table presents the mean logMAR values of the post-op vision in post-op day 1, 7, and 30 of 4 different IOL types, and it includes spherical equivalent values which measure the refractive error after surgery. And this is the data. Before surgery, mean patients had poor vision, which is less than 6/60, and on post-op day 1, there is significant improvement, but some patients still have vision in the range of 6/18 to 6/36, and post-op day 7, there are many patients with a higher proportion reaching 6/6 to 6/12, and on post-op day 30, most patients have 6/6 to 6/12 vision, indicating successful visual recovery. And the uncorrected and the best corrected visual acuity were analyzed on the final 4th week follow-up were considered. And the uncorrected visual acuity, as lens, there is a majority of patients fall into the 6/6 to 6/12 category. In IHANS compared to S lens, there is less number of patients like with in the 6/12 category, less than 6/12, and smaller portions. In Alcon, best uncorrected visual acuity results are seen. And in the best corrected visual acuity S lens, majority of patients have 6/6 BCVA, with smaller proportions having 6/9, and the Alcon highest number of patients achieve 6/6. So the overall trend suggests that all patients perform well, with most patients achieving good visual correction. So that there are few limitations of the study. The technique IHANS is not a pure monofocal IOL, and this study size is small. So the conclusion is there is comparative visual outcome achieved in patients implanted with acryls of lens and Hoya iSet, and those implanted with IHANS had relatively lesser proportion achieving 6/62. So for patients who cannot afford high-priced lenses, there is no significant difference in the obtainable visual acuity post-surgery. Thank you for your kind attention.
So these lenses seem to be all higher end only.
Like 3 are imported and 1 is India-based company.
Okay.
So
what were the reasons for the vision between 6, 9, 6, 12 for eye hands?
Eye hands, it might be because post of corneal edema. So, and ultimately, the eye hands, the distance vision following after correction, majority patients achieve 6/6. So the overall result of eye hands is like better because there is intermediate correction. So patients were very comfortable post of with eye hands.
All right, thank you.
Thank you.
Dr. Kritika. Yes, ma'am. I think last third. Last third, right? Yes, ma'am.
Dr. Kritika is going to be presenting visual rehabilitation in keratoconus, seeing clearly with specialty contact lenses.
Good evening, everybody. Today I'll be talking about the paper, my paper, that is visual rehabilitation in keratoconus, seeing clearly with specialty contact lens. So what is keratoconus? As we all know, it's an asymmetric, bilateral, progressive, non-inflammatory ectatic corneal disease that results in high irregular astigmatism and reduced vision ultimately, which can be corrected conservatively by using either spectacles or contact lenses. When we talk about the contact lenses, in a case of keratoconus, we can use either, we should be using only the specialty contact lenses. Why? Because we cannot use soft contact lenses, as soft contact lenses take the contour of the cornea, that is the irregular cornea, and hence it gives the same refractive outcome as a spectacle does. Hence, rigid gas permeable contact lenses based on diameter, such as corneal, semiscleral, and scleral lenses, are very useful in treating a case of keratoconus for visual rehabilitation. Aim of the study was to evaluate visual improvement with specialty contact lenses in patients of keratoconus treated post-corneal cross-linking. This was a retrospective study held at a tertiary eye center, wherein 57 subjects were included in the study from the year 2017 to 2021, where BCVA, best corrected visual acuity, was recorded by Snellen chart both with glasses and RGP contact lenses. Data of keratoconus patients treated post cross-linking who were prescribed with specialty contact lenses post C3R were included regardless of age, sex, or any pre-existing morbidity, while those with corneal degenerations or those ocular morbidities hindering the vision, like corneal dystrophy or corneal degeneration, were excluded from the study. The results of our study say that majority of the cases, majority of the subjects were in age group of 20 to 30 years, that is around 29 to 40%, and they were all male. So 36 of patients were included in the scleral RGP lenses and 21 of them were in the corneal RGP lenses. When we compared the best corrected visual acuity pre and post specialty contact lens usage, overall, both with scleral RGP and corneal RGP, vision drastically improved. But though statistically not significant, the scleral RGP lenses proved to be better than corneal RGP, though statistically not significant. So the discussion is that RGP contact lenses provide a tear layer between the irregular corneal surface and the contact lens, thus providing excellent vision for patients with keratoconus and improve patients' quality of life. Significantly better visual acuity was achieved with specialty contact lenses as described when compared with spectacles in patients, especially with keratoconus post cross-linking. There was no significant difference in BCVA between scleral and corneal RGP, as proved by a similar study by Levy et al. So I conclude saying specialty contact lens proved to be a boon for patients with advanced keratoconus, poor visual prognosis, and unsatisfactory visual outcomes with glasses. The study reinstates the gratifying outcomes with specialty contact lens in terms of quantity and quality of vision in keratoconic eyes, and of the two contact lenses that were prescribed, scleral contact lenses were found to be better rewarding and comfortable. Thank you.
So what are the two specialty lenses you used? Was a RGP
Yes,
and a scleral contact lens?
yes, ma'am. The scleral contact lens is
Rose
in the
K,
corneal.
is it a rose K lens that you used or RGP?
Ma'am, the Roski, we don't practice in our setup.
So, because an RGP lenses are usually not okay for all the kind of keratoconus.
Yes, ma'am.
Because the stability wise and everything, it always fails.
Yes, ma'am.
So either you use a rose K or you'll use a scleral lens.
Yes, ma'am.
Scleral lenses are more comfortable.
More
So,
comfortable.
so in your
Mini-scleral
study you
lenses.
did not use any of the rose K?
We have used mini-scleral lenses and the corneal lenses that were, it was manufactured by a private laboratory, ma'am. The name is Silverline Laboratories. So we used that in the study, ma'am.
Yeah, because the RGP lenses are usually not very stable for keratoconus.
Yes, ma'am.
Because
Yes, ma'am.
keratoconus, your cone is little decentered.
Yes,
no?
ma'am.
So it's
The
very
risk of
difficult to fit it.
decentration of lens. Yes, ma'am.
Yeah. Stability is not good.
Yes, ma'am.
And what was the criteria for you to take the patients in one group and the other group?
Ma'am, we have not taken any grade as in we have not separated as such. We've taken all the keratoconus patients post C3R. It was a retrospective data. So,
After how many weeks or months of post CXL did you give the lenses?
3 months, ma'am.
3 months.
Yes, ma'am.
Okay. Thank
All
you.
right, thank you.
Thank you, ma'am.
Name of your study?
Visual outcome and complications of surgical outcome of secondary posterior iris contact. Go ahead.
Dr. Neela.
Good evening, everyone. My topic is visual outcome and complications of secondary posterior iris claw intraocular lens implantation in aphakic patients. As everyone knows, cataract is the leading cause of reversible visual blindness across the globe, and most common surgery as of now is performed are MSICS, flags, everything. Secondary IOL implantation in a case of loss of capsular support include angle supported anterior chamber IOLs, scleral supported IOL, and iris claw anterior chamber and retropupillary IOLs. So Professor John Wurst developed the IC IOL attached to the anterior iris in 1972, and secondary implantation of retropupillary have been the preferred procedure in cases where iris support is feasible. So this study was done to assess visual outcome in patients undergoing retropupillary implantation of iris claw, and to study post-operative complications of iris claw and its implantation, and BCVA at the end of 3 months and 6 months, and effect on endothelial cell count. And the study included the outpatient department patients, and it was a prospective interventional study done for 15 months from August 2022 to September 2023. And this study included 63 patients. The inclusion criteria was patients willing to give informed consent, and patients with insufficient posterior capsular support, endothelial cell count of more than 1,200 per mm square, and aphakic eyes with grade 1 or less cells in anterior chamber at the end of 1 month post-op following cataract surgery. And exclusion criteria were pre-existing retinal pathology and corneal pathologies, gross iris abnormalities like aniridia, traumatic cataract and complicated cataract, glaucoma, and patients with high myopia and uveitis. So the patients attending OPD were assessed history-wise, and the clinical examination was done, and all 63 patients were included in the study with inclusion criteria, and ocular examination was done. Surgical technique, a single surgeon after a written informed consent operated all the cases. Following automated anterior vitrectomy, the patients were implanted with XL iris claw lens with a total length of 8 mm and 5.5 mm optic size. The size of the incision was 5.5 mm and superiorly was taken, and the iris claw inserted at 3 o'clock and 9 o'clock position. And post-iris fixated IOL was implanted using an iris claw IOL forceps. Peripheral iridectomy was done, and suture was placed to seal the wound. Follow-up was done 1 day, 4 weeks, 6 weeks, and 3 months and 6 months. Specular microscopy was repeated at 6 weeks and 6 months. The results were, according to the age group, many of them were 61 to 70 years, and most of them were males. And according the right eye was most common, most commonly preferred over this study. And postoperative best corrected visual acuity was improved to 6.9 to 6.6 by the end of 6 months. And the refractive error most commonly was noted was compound myopic astigmatism. The preoperative evaluation and the postoperative evaluation of the endothelial cell count showed significant results, and the 2.8% loss was noted at the end of the study and at the end of the 6 months. This was the IOP variation. And the most common complication noted was fovalization of pupil and the iritis, which was the most common complication. And this was the most common complication, that was ovalization, which was seen in our patients. The best corrected visual acuity was found to improve significantly by the end of 6 months, and ECD loss was not significant due to position of the IOL away from the corneal endothelium. Cystoid macular edema is noted only in few patients and was noted resolving with reduction of macular thickness. And retropupillary ICIOL implantation in eyes with inadequate capsular or zonular support is safe, faster, and effective procedure with good functional outcomes and fewer complication. Thank you.
So what was your incidence of TAS? I think
Yes, ma'am.
you've shown that.
Yeah, this
What was the incidence of TAS?
Yes, ma'am. 73% was noted.
How much?
73.
Isn't that too high?
Yes, ma'am. It was too high, and like after 2 days, it was resolved.
No, obviously TAS
Yes,
will
ma'am.
resolve.
Yes, ma'am.
But why should you have TAS so much, such a high percentage? of TAS?
Because initially it was noted due to NS, ma'am, and then we stopped, and it was almost normal after 2 days. So and then we thought this might be iritis, so we included that in iritis part.
So that means you were having the same
Yes, ma'am.
symptoms,
Same symptoms.
same findings, but
Yes,
you then
ma'am.
put it in the bracket of iritis.
Yes,
is that
ma'am.
it?
Okay. Yes, ma'am.
Was this procedure a primary procedure or a
Secondary
procedure?
procedure. Secondary procedure.
And was the suture given to these
Yes, ma'am.
patients?
Suture was given to all the patients, and it was removed after 45 days. And then this astigmatism and corneal endothelial cell count was taken at 6 months and 6 weeks.
How did the intraocular pressures behave in these eyes?
Ma'am, initially due to iritis and all, it was high, and then it was managed medically, and it was fine at the end of 6 weeks, ma'am.
What about the endothelial cell count?
It was not significantly reduced, ma'am. It was only 2.8% loss at the end of 6 months we've noted in this study.
So in your study, which was the most common complication?
That was like iritis at the end of the 2 days, ma'am. Like
73%. Which is very. Thank you.
Thank you, ma'am.
So thank you everybody for your lovely presentations. I think everybody was really very good, brilliant. Thank you so much. Bye bye. I think results will be coming later.